Alim. And next slide, please. Next, please. I have the honor to introduce Dr. Shahbaz Ali Khan from Lucknow, Nawabon ka Nagar hai, Nawab Khan. Professor and head of the Department of Psychiatry, Army Command Hospital, Lucknow. He did his MBBS from Mount Force Medical College, Pune, and MD also from FMC. 17 years service of professional experience on mental health, research papers published by many national and international journals. Areas of special interest is child and adolescent mental health and addiction. Welcome, Dr. Khan. Next slide, please. Dr. Amit Arya, also from Lucknow, smiling here on the photograph as well as when he was on screen. He is additional professor and of the Department of Psychiatry, King George Medical College University, Lucknow. Publications, national and international journals, 48. Awards and honors, Tara Naidu Award, Best Research Paper Award in field of Child Psychiatry 2019. Past Executive Council member of Indian Association of Child and Adolescent Mental Health. Past convener, SLD Task Force of IPS. Areas of interest, child psychiatry and neurodevelopmental disorders. From now onwards, the Thursday musing will move on and it is handed over to the chairpersons, Dr. Khan and Dr. Arya. Please take over.
Thanks a lot, sir. Thank you. Yeah, I'm Dr. Amit Arya. I'm audible to all?
Yes, you're quite audible to me, means you're to all. I am unmoved.
Yeah. A very good evening to all of you. First of all, very thank you to the organizing committee for inviting us for a wonderful talk on ADHD. And this is all of us are interested in child and adolescent psychiatry, especially ADHD. I take pleasure to invite the speaker of today's program, Dr. Nishant Goyal. We all know him well. He's professor and in charge of he's professor of psychiatry in charge child and adolescent psychiatry at CIP Ranchi. He is a joint secretary and founder member of Neuromodulation Society of India. He is editor, Eastern Journal of Psychiatry. He has more than 90 publications in national and international journal. He has 20 plus awards and fellowship to his credit, and his areas of interest obviously is child and adolescent psychiatry, neuromodulation, in psychiatric disorders, and public mental health. So he is right person for this topic. And now I invite and request my co-chair, Dr. Shahbaz, to introduce the topic of today's program.
Thank you, sir. Am I audible, sir?
Yeah, you are audible.
Okay. First of all, a very chilly evening from Lucknow to all of you, all the attendees. And I also have to extend my proud privilege and that we are a part of this beautiful initiative. And as we just saw, this is a conference on the move. On the move, everybody, all the trio, the initial trio, the stalwarts are moving, and they are doing this on the go. So that is really, really appreciable. And a big thank you has to be said from all the beneficiaries to the musings organizers, the trio that I named, Dr. Tufan Pati, Dr. Amrit, and Dr. Alim. Big thank you from all the attendees, sir. And God's strength to you to let this be continued forever. Now, today's topic is on ADHD, pragmatic management. We hope to go to listen from an illustrious speaker on the topic, the head of the Child and Adolescent Psychiatry Division at CIP, a specialist of the topic on the pragmatics, that the practical management part. As we all know, this is where we all get stuck, because theory is fine, but when we have and we've been having a deluge of ADHD and other neurodevelopmental disorders kids in a child guidance clinic post pandemic especially. So this is a very relevant and contextual thing to listen to. And before I invite the speaker, to begin with, what is psychiatry without poetry, as Dr. Vinay Kumar says. So yeah. Relevant to the context, I'll take a few seconds. Persian poetry, which encompasses the gist, musings of this ADHD and developmental management. It goes like this. Khishte awwal chu nihad mimar kaj. Khishte awwal, the first brick. Chu nihad mimar kaj. If the first brick is laid in a wrong manner, ta suraya miravad divar kaj. सुरैया आसमान तक भी वो दीवार जाएगी तो टेढ़ी ही रहेगी. That underlines the importance of foundational intervention, early intervention, and the kind of differences, changes that we can make, especially in conditions like ADHD. So without wasting much time, now I invite and request and hand over to the speaker, Dr. Nishant Goel, please.
Thank you, Dr. Khan. Just allow me to share my screen. Just give me a moment, please.
The stage is all yours, Dr. Nishant.
Thank you. I hope the slides are visible to all of you.
Yes, sir. It is.
So,
Yes.
Thank you. Thank you so much, respected chairpersons, my dear friend Amit. And I'm meeting Dr. Khan for the first time online. And at the outset, I would like to first thank the team of Thursday Musings for considering me to share a few thoughts and some data regarding management of ADHD. Thank you so much, Aleem, Amrit, and Tufanpati sir for having me today. So in the next 35 or 40 minutes, what I'm trying to do is to take you through the basic concepts of ADHD, some neurobiological aspects of ADHD, and how to manage, practically ADHD through understanding of various guidelines. Now, in this particular deliberation of mine, I have also touched upon the issues of adult ADHD, which gradually is picking up, and people are now trying to appreciate that there is something called adult ADHD. There is something called ADHD which actually goes to the adulthood and cause significant impairment or significant problems, in a particular set of individuals. So any story of talking about ADHD starts a story of fidgety Philip. Dr. Khan was giving us a beautiful deliberation. So this is a poem about the fidgety Philip. So let me see if Philip can be a little gentleman. Let me see if he is able to sit still for once at table. Thus spoke in earnest tone the father to his son. The mother looked very grave to see Philip so misbehaved. But Philip didn't mind. His father was so kind, he wriggled and giggled, and then, I declare, swung backward and forward, and tilted his chair just like any rocking horse. Philip, I'm getting cross. So this is a very, very famous poem describing fidgety Philip, like one of the very earliest, descriptions of ADHD. Which brings me to the basic history of ADHD, which started with the concept of minimal brain dysfunction way back in 1900s. Then as DSM came into picture, people started talking about hyperkinetic hyperactivity syndrome, which lasted till 1969, followed by recognition of attentional impairment and impulsivity. And mind it, like it's only been 15 years that people have actually thought of or have seen that inattention or impulsivity is the cardinal manifestation of ADHD, unlike hyperactivity, which was considered previously. Then the DSM-3 criteria came, and they talked about ADHD or ADD with or without hyperactivity. Then in DSM-3 TR, it became ADHD, which lasted till 1987. Then finally in DSM-4, which came in 1994, we came to understand the subtypes of ADHD in terms of inattentive, hyperactive, and combined subtypes. So if you see the differential diagnosis of ADHD to start with, like how it mimics or how does it mimic to? It mimics to mood or psychotic disorder, anxiety disorders, learning disorders, mental retardation or borderline intelligence, oppositional defiant disorders, conduct disorders, pervasive developmental disorders. So all these things you have to actually rule out. And I'll be talking about few of them in my further slides. Even children who are suffering from a lot of psychosocial issues like abuse and parenting-related issues do also present with symptoms mimicking symptoms of ADHD. There are certain medical, manifestations which also present like symptoms of ADHD, most notably absence seizures or complex partial seizures, hyperthyroidism, sleep apnea, drug-related inattention, so on and so forth. I'm not going to the details of all these things. Now, as I said, the cardinal feature of ADHD is inattention. You all know a child is described as careless, getting easily distracted, having difficulty sustaining attention, losing things easily, and being forgetful in day-to-day activities. Unlike our understanding of ADHD, that hyperactivity is a symptom which is cardinal. No, hyperactivity is a symptom which is most commonly seen or understood or visualized. How it is? A child is fidgety, doesn't sit at one place, keep on running around, talking excessively, always on the go, not waiting for his or her turn to say anything or to do anything, and he keeps on interrupting people around. Similarly, when it comes to adult ADHD or symptoms of ADHD which traverses to adulthood, we have to see that this concept, as I said, is gradually picking up. People are getting to understand there's something called adult ADHD, though people still have this myth that adults with ADHD is rare. Most of the people, even the mental health professionals, they believe that children with ADHD grow out of, as they become adult. Many people say that it doesn't exist. Then we all believe at times that everyone is distractible. So those people who are making excuses for being lazy or procrastinating, or they are not motivated. Or some people believe that ADHD is a result of our modern technological lifestyle. So all these things are commonly talked about, if or when ADHD is actually traversing into adulthood. Now, coming to the prevalence, if you see prevalence, it is different in different parts of the world. Overall, worldwide prevalence of ADHD ranges from 5 to 7% in adolescents less than 18 years, ranging from less than 5% in Europe to up to 10% in US. In our country, it is around 5 to up to 29 or up to 30%. If you see the difference is that in children and adolescent, hyperactive, impulsive, and inattentive symptoms, they are present in around 2/3 of the cases. More commonly, you will get symptoms of inattention in adult as compared to children and adolescents. Now, coming to some other aspects of epidemiology, as I was mentioning, ADHD is the most commonly diagnosed behavioral disorder of childhood. As they say, 1 in 20 worldwide. And I'm sure you will realize and understand it's a huge number. Male to female ratio is, is around 2 to 9. 2 to 9 is to 1. Like that means it is more common in male. All neurodevelopmental disorders, as we know that ADHD is a type of neurodevelopmental disorder, they are more common in boys prior to the age of 10 years. But by attaining adulthood, it is 1:1. Then the gender paradox says that girls typically show less hyperactivity, less conduct problems, and less externalizing behaviors. What I mean to say is inattention is more common in female gender as compared to male. But still, the findings are not very consistent. There are a lot of polygenic conditions which are associated. We don't have to actually believe truly that girls are less hyperactive, though it is the case if you see clinically. Then literature says that at least 50% of the people, they maintain the diagnosis of ADHD by the age of 15 years. The strongest predictor which has been found for its poor prognosis is pre-pubertal aggression. If a child before attainment of puberty remains aggressive as a part and parcel of ADHD symptoms, it carries a poorer prognosis. So over 80% of the psychotropics are prescribed by primary care physicians all over the world. It is not that mental health professionals are prescribing medicines. It is primarily prescribed by the primary care physicians. So, and it has been increasing gradually over a period of time. The same thing what I've been talking about, that ADHD male to female ratio in adult ADHD is 1:1. In children, it is ranging from 2.5 or 9:1. Then coming to evolution of symptoms, how with age symptom evolve. So you can see below is the timeline. it starts with hyperactivity, followed by development of simple symptoms of impulsivity. Then as a child grows or outgrows his age, having puberty or after puberty, symptoms of inattention, they come in the forefront. So this is how symptoms develop, and this is the usual time when when there is inattention creeping up and hyperactivity and impulsivity there, when you usually realize that the child is actually suffering from ADHD. And with age, it is found that inattention or symptoms of inattention, they either remain the same or they increase, and the symptom of hyperactivity and impulsivity, they come down. Now, many a times people ask this question that over a period of time, there has been a surge or increase in the diagnosis of ADHD. What might be the usual, pragmatic issues in terms of increase in the diagnosis of ADHD? Is it more recognized by physicians? Is there a true increase in the prevalence of ADHD? Or we are making the standards of diagnosis easier? And most importantly, are we making the standards of prescribing medications, easier? You'll not believe as atomoxetine was developed and approved by US FDA for treatment of ADHD years back, that the diagnosis of ADHD in America rose by more than 400%. So a lot of things are involved when it comes to increase in the diagnostics. Maybe increase in the scholastic demands, where children are supposed to perform more than usual, as we have been growing over a period of time. Now, how does ADHD or symptoms of ADHD, they cause impairment? Now, the domains of impairment, they vary in various age groups. Now, coming to children first, if you see on the right hand side of your screen, children with ADHD have more of academic limitations. They have difficulty making friends or maintaining friendship. They often have symptoms of poor self-esteem or lower self-esteem. Growing into adolescence, ADHD comes with a lot of injuries. Adolescent, they go on to try smoking, substance abuse. Further in life, people have a lot of road traffic accidents. Adults with ADHD have a lot of legal difficulties at times because of various issues related to workplace or in the family. And it is definitely associated with vocational and occupational impairment in adulthood. The same, if you see, as a child grows from preschool to adulthood, how developmentally ADHD or symptoms of ADHD are producing their impact. Now, coming to comorbid symptoms or comorbidities associated with ADHD. As you know, in child psychiatry, not only in ADHD, comorbidity is not an exception, but it's a rule. So a lot of symptoms of externalizing behavior disorders. The most common, if you can see, is oppositional defiant disorder. It is the most commonly associated disorder with ADHD, followed by conduct disorders, tic disorders, specific learning disabilities, so on and so forth. Interestingly, many studies have found anxiety spectrum disorders also associated with externalizing behavior disorders or disorders of ADHD. Now, studies mention that around 80% of children with ADHD demonstrate psychopathology as adults. As I was mentioning, that adulthood also has a lot of symptoms. So, as I said, they have educational impairment, employment problems, they have greater sexual reproductive risks associated with that, and problems with motor vehicle accident. Coming to the natural history of ADHD, as it is seen in many psychiatric disorders, the rule of thirds always goes with ADHD as well. 1/3 have complete resolution, 1/3 they continue to have inattention and some impulsivity. And 1/3 of the people who have comorbid oppositional defiant disorder or conduct disorder or poor academic achievement, they go on to develop substance use disorders and symptoms of antisocial or dissocial behaviors as they grow into adulthood. As I mentioned, with age, symptoms change from hyperactivity to inattention to restlessness. And impulsivity is something which starts late, but it persists till a later age in an individual with ADHD. Just briefly, I'll just touch upon the pathophysiology of ADHD. Understanding of pathophysiology is important because when you think of talking or giving medication in ADHD, you need to have basic understanding of pathophysiology of ADHD. Neuroimaging findings, they mention that that there is high density of dopamine receptors. The areas which have high density of dopamine receptors like globus pallidus or caudate nucleus, they are smaller in children and adolescents with ADHD. The posterior brain regions, cerebellar vermis, occipital lobes, they are smaller. So these areas where there is very high density of dopamine receptors are relatively smaller in these cases. Certain genes are commonly associated with ADHD. One is a human thyroid receptor beta gene on chromosome 3. Most commonly studied gene is the DAT gene or the dopamine transporter gene, which is commonly seen on a chromosome 5. And there is one dopamine receptor D4 gene on chromosome 11. So these are the genetic findings which you commonly see in cases of ADHD. These are the studies which I have found. Now, the famous dopamine theory of ADHD. We all know, and I'm sure we all will understand that there are differences in brain maturation, structure, and functions. And if you see the frontostriatal circuitry, which comprises of prefrontal cortex, basal ganglia, cerebellum, this loop or this CSTC circuit sort of a thing is associated with common executive functions like attention, working memory, short-term memory, response inhibition, and set shifting, which are seen to be, impaired as children with ADHD grow into adolescence and adulthood. Now, studies have consistently found that the mesolimbic pathway or the dopaminergic pathway of the brain, which begins in ventral tegmental area of midbrain and projects to nucleus accumbens, has definite issues when it comes to dopaminergic activity. Then the mesocortical pathway, the projections from ventral tegmentum area, that is the reward circuit, to mesocortical and DLPFC areas, they are consistently seen to be functioning poorly in ADHD, leading to inattentiveness and attention deficits, which is commonly seen in children and adolescents with ADHD. Similarly, the motor hyperactivity is found to be associated with problems in the nigrostriatal pathway. And that is how it says that impulsivity and hyperactivity is managed through nigrostriatal pathway, and they are found to be dysfunctional in children and adolescents with ADHD, consistently associated with smaller caudate nucleus and basal ganglia structure. Certain non-genetic causes of ADHD are also having some neurobiological role, like perinatal stress. If you take history in children and adolescents with ADHD, you'll frequently get history of perinatal stress, at times low birth weight, traumatic brain injury, maternal smoking, and early deprivation. Early deprivation is less talked about, but it's a very, very important factor when it comes to development of neurodevelopmental disorders, not only ADHD, but other disorders like intellectual disability or autism spectrum disorder as well. I've already mentioned about that most of the children with ADHD have impairments in executive functioning, which led to a lot of adult-related problems. And these are vigilance, response inhibition, working memory, and planning difficulties. Just a brief about DSM. I'll not read out the DSM-5 criteria for you guys, but DSM-5 and DSM-5-TR now have age-appropriate descriptions of ADHD. For example, in attention, they talk about history of mind elsewhere in the absence of obvious distraction. You'll see that the person is, engrossed in his or her own world. They have adults with ADHD, they have problem returning calls, paying bills. They have difficult time management and they are not able to meet deadlines. Or hame lagta hai ki they are just procrastinating. Children and adolescents, they frequently complained of being restless and uncomfortable while they are sitting at restaurant, meeting. They have difficulty butting in, they'll butt into conversation and activities, intrude into and take over what other people are doing and talking about. ADHD is associated, as per DSM-5, it is associated with delays in languages, motor and social development, a lot of emotional symptoms characterized by poor frustration tolerance, irritability, and frequent mood lability. I've already talked about cognitive deficits and education problems, so I'm not going to repeat this. ICD-10 recognizes ADHD as hyperkinetic disorders. So it is called hyperkinetic disorder, disorders of attention and activity. Most of the symptoms are similar to DSM-5. And it says that impairment has to be required in all the three domains, the three domains of hyperactivity, impulsivity, and inattention. And there is a provision where, as I said, there's a lot of comorbidity of conduct disorder. So they have a provision to make the diagnosis of hyperkinetic conduct disorder. So this is something which is very, very important. So I'm talking about impairment. So broadly, there are three domains of impairment you can see on this on your screens. One is the psychosocial impairment, one is psychiatric impairments, and then neurodevelopmental impairment. I've already talked about the neurodevelopmental impairment and risk for comorbidities. But children, adolescents, and adults with ADHD, they have frequent work and education related issues, having difficulty in making social relationships. They have difficulty coping with, performing activities of daily living, prone for accidents and behavioral problems. Now, a set of symptoms which mimic, or the impairment of those things mimic with impairment of symptoms of ADHD. You can also call it differential diagnosis. One is anxiety. Anxiety in adolescents also, the adolescents have complaints of excessive mind wandering, worrying about performance deficits. But it is not, as in ADHD, it is not associated with avoidance of situation, which is commonly seen in anxiety spectrum disorders. Depression. There is always a hue and cry and say that at times manic symptoms look like symptoms of hyperactivity in ADHD. Inattention mimics chronic low self-esteem, instability of mood, impatience, irritability. Though depression is not very commonly seen in or associated with ADHD, but you might get confused with the symptoms of low self-esteem very commonly. Then very commonly these days, we are seeing starting of development of borderline personality in children or adolescents who have history of ADHD. So they come with a lot of behavioral problems, emotional instability, impulsivity, and difficulty in maintaining, social relationships commonly. And as I said, bipolar disorder, at times hyperactivity and restlessness of bipolarity is confused with the restlessness of ADHD. The most common way of differentiating is that biological functions are usually maintained in ADHD as compared to bipolar disorder. There are other factors also. If anyone is interested, I can talk about it later on. As I said, in adult ADHD, a new symptom threshold has been described. When it comes to inattention, they say that the problems should be there in more than one setting. The settings, the example of the settings is home, school, and in case of adult, work. The contribution of informant is very, very important in terms of, making a diagnosis of ADHD. So the differences which DSM-5 talks about as compared to DSM-4 TR or ICD-10 for that matter of fact, now it says that the symptoms have to be present before the age of 12 years. In children, there should be at least 6 out of 9 symptoms of inattention. In older adolescents and adults, at least 5 out of 9 symptoms of inattention have to be there, which are described in DSM-5. Same thing holds true for the symptoms of hyperactivity and impulsivity, which are clubbed into one phenotypic category. So these are the summary of some symptoms. You can see hyperactivity presents with fidgety behavior, inability to sit still. Inattention presents with distractibility, disorganization, being bored very easily, always yearning for variations, having difficulty in making decisions. And now this is the summary table of DSM changes. In DSM-4 it was less than 5 years. In DSM-5 it is less than 12 years. Just change in the number of symptoms, as you can see. Now coming to assessment, I'll be gradually moving towards management of ADHD. Now I'll take another 10 minutes or so. The assessment tools, though ADHD is a clinical diagnosis primarily, but we do have various type of assessment tools. They are broadly classified into broad-based band instruments where you evaluate behavior and psychosocial functioning. We commonly use in our settings, which is something called strength and difficulties questionnaire. Global assessment of functioning is not used these days as commonly as SDQ. Narrow band scales, which are specific to the symptomatology of ADHD, includes Conners, Vanderbilt, ADHD rating scale, Brown. So there are a lot of rating scales. When you are profiling a child or adolescent with ADHD, it is not a bad idea to evaluate for comorbid conditions. So you look for symptoms of conduct by CBCL, or maybe development of personality, using some scales measuring impulsivity or emotionality in these children and adolescents. So to establish a convincing diagnosis of ADHD, it is extremely important to have collateral interviews. एक आदमी से बात करके आप ADHD का diagnosis नहीं बनाना चाहिए. You have to talk to the child or adolescent, primary caregivers. We have to take history from school teachers, coaches, if they're going to music classes or sports, talking to them. Then I'll not go into the details. I've already talked about this, so I'll just skip this. Gradually moving to the guidelines for ADHD. Now, any guideline or any method or any pragmatics of managing ADHD should follow a share approach. There are two approaches. One is called the share approach. Another is called the multimodal treatment of ADHD, MTA approach. I'll talk about that in the next slide. So share stands for seeking patients' participation. It is extremely important that you engage with the patient party while you are actually working with them, managing the symptoms of ADHD. So S stands for seeking participation. H stands for helping our patient explore and compare treatment options. It's not that आपको यही करना है. A stands for assessing the values and preferences of your client. R stands for reaching to a decision, and E stands for evaluating the patient's decision on the treatment which you are prescribing. The other approach I was talking about, which is still supposed to be one of the most comprehensive study in terms of management of ADHD, is called the multimodal treatment approach, which talks about including psychoeducation, parent training, behavioral intervention, liaising with school, individual and family counseling, and use of medications if and when required. Now, first talking about the AAP guideline, American Academy of Pediatrics guideline, which came in 2019. This is the latest revision of this particular guidelines, where they say for preschoolers, parent training and behavioral management should be done in all the cases. Though they say that methylphenidate can be considered in failed cases, but it should be kept reserved for moderate to severe cases. As a child grows, into elementary school stage, pharmacotherapy and combination of behavior therapy has the strongest evidence. The best evidence is still for methylphenidate. Atomoxetine is also used in certain cases. In adolescent, app prescribes medications for ADHD with the assent of the adolescent and consent of the guardians. They say that you can use anything, but in most of the cases, behavior therapy is also used in these particular cases. They say that you should ADHD should from the beginning identified as a chronic condition, and management should be given for at least 2 years to start with, and it should be increased if it is required. Then the Canadian guidelines, they prescribe long-acting stimulants, particularly methylphenidate is available as a long-acting stimulant with them as a first-line agent, followed by immediate release preparations, atomoxetine as a third-line agent, and clonidine, modafinil, and bupropion as third-line agent. Similar descriptions are given in UK by the NICE guidelines. They say that when a decision has to be made to treat a child or an adolescent, young adolescent with ADHD, you should always consider that there are comorbidities. When to use methylphenidate in a case of ADHD, you have to be very, very cautious. When there are comorbidities, usually methylphenidate doesn't work. Suppose an adolescent has tics or Tourette, methylphenidate is better than atomoxetine. So these are some pragmatic ways you have to pick and choose a particular medication when you are managing patients with ADHD. So they also say that using modified release preparations or delayed release preparations are also considered for the term for the sake of convenience, adherence, and the pharmacokinetic profiles. Psychoeducation is extremely important, extremely important in managing ADHD. Mind my words, you can't manage, a child or adolescent with ADHD by giving them 10 minutes in your chamber, writing some medicines, or sending them to a psychologist or a special educator for behavioral management. It requires systematic, structured, evidence-based programs. The psychoeducation program should be eclectic. You should have a lot of material. It is available on internet. Main therapist and co-therapist should be included in psychoeducation. It is not that only one person is giving psychoeducation. People have found that weekly sessions lasting for 4 to 6 weeks, they carry a good prognosis. It can be given in group sessions, like you can have a group of 8 to 10 people and provide them psychoeducation. Then when you are managing these cases, other problems, quote unquote, they are also key in providing holistic care in patients with ADHD. Assessment of sleeping and eating difficulties, mood symptoms. As I said, liaising with school is very, very important. Pick a teacher who understands that child, that a child or adolescent has a problem. Assessing the needs of the parent training, it is very, very important. Cognitive testing and looking for requirement of occupational therapy also is very, very important. So in nutshell, you have to work with the child, you have to work with the parents, and you have to work with schools. This is just an example of some attentional enhancing tasks, which we commonly use in our day-to-day practice when we are managing inattention, not only in cases of ADHD, but ADHD with autism spectrum disorders, or maybe borderline intelligence to mild mental retardation. We are using all these things. I'm sure, I think the Department of Psychiatry in KGMC Lucknow, they are having structured programs. I'm sure, I remember attending a workshop done by, I think Dr. Amit
Yes.
Arya was there.
Yes, we conducted it.
If I remember correctly.
Yes,
So I'll not go into the details of the pharmacological intervention. These are all given in the books. Many of you might be knowing about how methylphenidate works. It blocks the norepinephrine transporters in the prefrontal cortex, reducing the reuptake of norepinephrine dopamine. The concentration increases, and it leads to improvement in the executive function through the mesocortical and mesolimbic pathway. The problem with methylphenidate is half-life is very less. So you have to give twice daily or thrice daily, or at times 4 times a day dosing. That is how we use sustained release preparation, which can be given once daily. Usually methylphenidate is available in the formulation of 5, 10, and 20 milligram. And the controlled release preparation, which is available in India by the name of Concerta, it is available by 18 and 36 milligrams. Atomoxetine is something which is a non-stimulant. which is a specific norepinephrine reuptake inhibitor. Mechanism of action more or less is the same, but problem is methylphenidate is a scheduled drug. Atomoxetine is not. So it has got less of side effects than other drugs which are used commonly in presence of intellectual disability or hyperactivity is very common, is clonidine. Or they say guafencin, but guafencin, as far as my knowledge, is not available in India. We use low-dose risperidone, haloperidol, and other antipsychotics like aripiprazole in some cases, but it is rarely used these days. So this is the difference between stimulant and non-stimulant. As I said, stimulants are scheduled drugs, so a lot of paperwork is associated with them. They're very safe. Atomoxetine is also safe, but efficacy-wise or effect size-wise, if you see in this particular slide, the best effect size is still for stimulants. Stimulants carry a large effect size. You can see long-acting stimulants have the best effect size, followed by immediate release stimulants and non-stimulants later on. So patients in which now pragmatically where you should consider using stimulant. So people mood instability or severe mood dysregulation or DMDD for that matter of fact. So we use mood stabilizer. In my clinical practice, I am more in favor of using lithium, because lithium is something which will take care of the mood as well as take care of the impulsivity. So आप एक तीर से दो शिकार कर सकते हैं if there is no clear-cut obvious contraindication for using lithium. So lithium can be used. You can use drugs like aripiprazole or quetiapine as per the phenotype of the individual. Over to you.
So aripiprazole and lithium, I think
Yes.
is a very good combination.
Yeah.
Sir, a very important clinical question: if the patient with ADHD with hyperactivity or behavioral issue is not responding to methylphenidate, clonidine, and atomoxetine, then how to go about it?
See, that's what I was just mentioning to the previous question, that if a person is not responding to first methylphenidate, you have to see why a person is not responding. Just talking about that ye dawai kaam nahi kar rahi, ye dawa kaam nahi kar rahi, doesn't work like in any neurodevelopmental disorder. So you have to see why a particular medicine is not working. We have options of combining methylphenidate with low-dose antipsychotics. Commonly used antipsychotics are risperidone. Risperidone has the best evidence. Haloperidol also has some evidence. If there are no obvious contraindications to use of haloperidol, very low-dose haloperidol also works wonders in improving hyperactivity of ADHD. Then definitely some people, they do consider using mood stabilizers also as an augmenting agent. But in my clinical practice, I usually avoid doing this. So what I will do is, if a person is already on methylphenidate, I might think of adding low-dose antipsychotic or atomoxetine if one drug is not working. So this is like a few ways of handling such cases.
Sir, there are two questions related to the differentials. How you differentiate ADHD and mental retardation with behavioral issue and vis-a-vis autism spectrum disorders.
Yes. So as I said, that intellectual disability and autism spectrum, they are commonly associated or comorbidly present with ADHD. Now, IDD. In IDD, history is the key. Developmental history is the key. You will definitely get symptoms of or delayed milestones of development in children with IDD. Behavioral symptoms, particularly symptoms of aggression, irritability, hyperactivity, it usually starts early as compared to presence of these symptoms in ADHD. The second differential is autism spectrum. It is not very difficult to tease out the symptoms of autism spectrum from symptoms of ADHD. Autism spectrum definitely has clear-cut impairment in communication. In ADHD, communication deficits are not that commonly seen. You do get difficulty in communication, but that reciprocal communication or qualitative and quantitative issues with reciprocal communication is usually not seen in ADHD. But as I said, at times autism and ADHD, they are comorbidly present. There is a, we call it, I'm sure Shobhit will realize, there is a category in ICD-10, which is included under pervasive developmental disorder section. This is called overactive disorder with mental retardation with stereotypic behaviors. So this is one category which is reserved, where you have symptoms of hyperactivity also in the context of intellectual disability and impulsivity and other repetitive behaviors. So you have to see this, the development of symptoms, how the symptoms are developing over a period of time. As I said, hyperactivity, differentiating the hyperactivity of MR and hyperactivity of ADHD at times can be very, very difficult. So the age of onset, the context in which the hyperactivity is, shown and seen, and the goal directedness of that particular hyperactivity. There are some key which differentiate between the hyperactivity of ADHD and mental retardation. Over to you.
Yes.
Sir, a sequential based question that can ADHD be diagnosed in adults without any symptoms in childhood, like the 7 years criteria or 12 years criteria? If we take off, is it possible?
See, very clear cut, very simple. To diagnose anyone with adult ADHD, you have to demonstrate that that guy had symptoms of ADHD in childhood or adolescence. Period. It is clearly written in DSM that you have to demonstrate that the symptoms were present. They might have got missed. People might have not seen it or realized or talked about it. But you have to, when you go back to the history, you have to demonstrate that symptoms were there in either in late childhood or adolescence.
Yes.
So you're involved with a lot of school community-based programs. The question that are teachers in India taught specifically to handle or identify children with ADHD?
Again, it depends upon when you talk about ADHD from a school perspective. So again, it depends upon the age of the child. Suppose you are talking about a 9-year-old person or a 10-year-old person, where the school teachers, they complain to in the parent-teacher meeting that the child is very hyperactive, not sitting at one place. So it is very common these days in the era of Facebook, WhatsApp, and social media that koi bhi bacha who is not sitting at one place or who is not paying attention in the class to be labeled as ADHD. But this is my humble request. I'm sure Amit will also agree to me on this.
Yes.
That we have to have a liaison with school counselors if they are present, or it's not a bad idea that you have a group of people who are going to the school and evaluating those children who are identified by school teachers, and to make them understand that any mindlessness or any inattention is not ADHD unless proven otherwise. As I said, you have to demonstrate the impairment in at least 2 or 3 contexts: home, school, and at times, with friends while playing and at work. Just because bacha class mein nahi baith raha hai ya bacha class mein dhyan nahi de raha hai, we should not label a person with ADHD.
The important question Dr. Aleem has posted that about drug holidays. So, what is the minimum duration, maximum duration? How to go about it in our context? So, can you elaborate with a personal experience of this?
See, personal experience wise, if you ask me, I usually prefer a drug holiday of at least 7 to 15 days, while the child is not attending or adolescent is not attending the school regularly. Usually summer vacations के time में या winter vacations के time में we usually say that हम लोग ऐसा दवा कम करके देखते हैं या कुछ दिन के लिए दवा को बंद करके देखते हैं. In my clinical experience, I would say in more than 70% of the cases where I exercised drug holidays, there was no apparent impairment or there was no apparent relapse of symptoms of inattention. And I mind it, I do drug holidays only for methylphenidate. There are talks about using it for atomoxetine also, but I have not done in my clinical experience. So it is only with methylphenidate, and that too methylphenidate, which I'm using as a sustained release formulation, particularly Concerta. So I do, because Concerta is a very costly molecule. So कुछ लोगों में कुछ दिन के लिए अगर हम Concerta बंद करते हैं तो they are happy about it and they are ready to continue it further. So it's a very pragmatic issue when you work in practice.
So nowadays, naltrexone has been pushed in trans-diagnostic symptoms. So your take on it, its effect on hyperactivity or behavioral issues associated with ADHD, sir?
Okay. See, frankly speaking, we have used naltrexone in our clinical setting, particularly in the context of impulsivity and self-injurious behaviors. But that too in the context of intellectual disability or moderate to severe intellectual disability. I personally have not used with naltrexone for managing symptoms of ADHD primarily. Yes, you can say that it can be used as you can combine it with say atomoxetine or maybe low dose risperidone, but at least I have very limited experience of using naltrexone for this particular purpose. I could not find, I'm sure my moderators can throw some light, but I could not, even transdiagnostically also, I'm not finding any reason to use naltrexone in a case of ADHD. Primarily, even adolescent or late adult, late adolescents or early adolescents.
Right, sir. Sir, there are 2 to 3 delegates who want to exactly know how you titrate the doses of methylphenidate.
Of?
Methylphenidate, sir.
Methylphenidate.
I think I mentioned in one of my slides that usually per kg body weight we do. I usually start with 5 milligram. And if a person is tolerating it well, after say 3 to 5 days, I make it 10 milligram. So as per kg body weight, we go up to maximum of 20 milligram in a day. When I'm using 20 milligram in a day, I'm using it in divided doses. So generally 10 milligram हम लोग सुबह में जब स्कूल जा रहा होता है बच्चा तब दे देते हैं, and 10 milligram we give once the child comes back from school. So this gives us coverage, right? If I'm using Concerta, suppose if I'm using Concerta, which is available at 18 to 36 milligram, I don't start anyone with Concerta straight away with 18 milligram. I usually start with immediate release, reach up to the target dose of 15 to 20 milligram, and then shift over from twice daily regime of the immediate release to once daily preparation of Concerta, usually giving them in the morning with the breakfast when they're going to school. So this is the usual way I titrate at methylphenidate.
So one more last question. Sir, a lot of people are curious about duloxetine. Duloxetine, is it safe and is it effective? So, your views on it.
See, if you ask me, I'm not a very, I'm not the right person to talk about using different type of drugs for the same issue. I have never used duloxetine. I have no, hesitation in accepting it that I have never used duloxetine for, particularly managing symptoms of ADHD. There was a drug which came many years back called reboxetine, if you remember. Now it is not, available. I think it is not available and not used these days for, social issues, particularly, adolescents having difficulty in making friends. They have social anxiety symptoms. We did try reboxetine in certain cases, 2 to 4 milligram per day. But again, it was not very effective. I would still say, Shobit, for me, methylphenidate is the wonder drug for managing, if you're talking about medications. Methylphenidate is a wonder drug, but it has to be used pragmatically, properly, cautiously, and with proper, you have to keep on checking for many things like body weight, height, and the mood of the individual. So this is what it is.
And so a lot of delegates are requesting about the slides. Dr. Aleem Siddiqui sir has already put the link in the chat box. I think you can access the recording from there. I think for question answer sessions, I think we are done with the publishing the chairs. Thank you.
Yeah. Thank you, Dr. Shobit. Yes. Doctor, yes.
Yeah, just a small thing. Wanted the speaker's input on this FDA approved non-pharmacological, this video game which has come, Endeavor treatment. Any input on that, sir? For the benefit of all.
Sir, a lot of apps and video games are available now, but do see that you are using these apps and video games for not for treating ADHD. You are using it for treating a particular phenotype or a particular symptom cluster. the best way is to understand is anything which improves attention span of the child or the adolescent. People are using video games, they are using apps. Sir, recently, when Dr. Amit Arya was talking about viloxazine, I think 2020 US FDA approved something called external trigeminal nerve stimulation uh, for treatment of ADHD in adolescents. Unfortunately, it was done in US, and the company which is making that particular machine, it is not marketing that machine outside the US till now. And as he has already mentioned about other neuromodulatory techniques. So definitely assisted technologies using apps, video games, or maybe social stories. All these things are used very commonly in management of various symptoms of ADHD. Sir.
Thank you, sir. Thank you. So that was a very really holistic, kind of coverage of ADHD, and especially on the pragmatics part of it, and especially to focus the multimodal approach and all the headings that has to be touched when the child comes to us. A few inputs from me, from my personal experience in my child guidance, sir. Since it is about pragmatics, basis sticking to fundamentals. First of all, as psychiatrists, it pains us when the child at 13, 14 comes to us, a girl in 7th struggling with studies, and that the parents somewhere knew around 5 years back since, and they are educated people, and somewhere that deficit, that lack of connect is there, which really pains us as psychiatrists. And the amount of change we have when we intervene, I mean, it is phenomenal. So we can use it as a template for others. In the same breath, we can say that a formation of group, WhatsApp group of the parents really helps in catharsis and skill development of them. Then important one thing, very practical and basic things. So my wife, she's a psychologist. She says, and she uses this thing called praise.
Yes.
In the management of it is a small word. I didn't believe in it, but when I saw the amount of change it can bring, so the child is like on board. Initially, he was like tussle between us, and now he's on board just with the praise. We tell the teachers and with the parents and us. Praise does a huge amount of things. The stars thing, the 5-star, and a lot of other. The reinforcement thing, the really non-familiar thing helps. Then I have seen in practical this thing, communication between psychiatrists and the teachers, communication between psychiatrists and the counselors. It really helps in individual cases. In my case, in many cases, they have phenomenal effect. In fact, when sometimes the parents come with a tussle with the teacher is doing this, teacher is not letting him sit in the class, teacher is making him stand outside, and there's a kind of a tiff between. So what we explain to them is, see, the teacher is the ecosystem there. You cannot remove her. And with all her, with no disrespect to the teachers, most of them are doing a good this thing. But in some cases, when we tell the parents to, take the teacher on board, and what I say is, massage them properly, their egos to massage. Ma'am, you are doing a great job, and yesterday you told him to sit in the class, and I found a huge amount of change in the way he sat doing her homework. If you can just involve yourself a little bit more, it'll do wonders, and the teacher is on board. So the whole ecosystem has to be brought in, like the psychoeducation and the multimodal part. That I have seen in my practical experience. It really helps. Then important thing, like we have to understand, the importance of retaining the child in therapy, the importance of ensuring the next visit. And apart from the standard drug management and side effect management and other things, just one thing, sir, I have to bring out to all the delegates here. There's the importance of obstacles to treatment, the pathway to recovery and pathway to healing approach. There are huge obstacles there. There are huge obstacles. We have to understand the child. There has been a lot of shouting, yelling, going on before the child has come to our clinic. So our approach from the start has to be really, really good. I am reminded of an anecdote. I'll just relate here. My mentor who introduced me to child psychiatry, retired Air Vice Marshal Dr. R.C. Das sir at AFMC. He used to say a very small thing. He always asked us to talk to the child first. It was an adolescent. Talk to the child first, so that in his mind doesn't see you as a collaborator, because a lot of things have happened before they have landed up in your clinic, and that I've seen it really works there. And not to forget the caregiver, So these are the small inputs from my side. Since I started with the poetry, sir, I have to end with the poetry if you allow me.
Yes.
So
Definitely.
now from Persian poetry, it is still in Persian poetry, but now the poet is Asadullah Khan Ghalib the Great. So a very beautiful poem I found relates to our children suffering like this. The poem goes like this: a raindrop when it starts its journey from the clouds, high clouds, and it is looking for that oyster where it will land and become a pearl. This raindrop can be, is analogies that our child and looking for a reformative thing, which is the oyster, which will convert it into a pearl. But there are 100 crocodiles also opening their mouth in the same wave. So it is very difficult for the child to land up in that oyster and not to land up in the crocodile's mouth. So the poem goes like this: Dam har mauj mein hai. Dam is the trap, net. Dam har mauj mein hai. There's a net, there's a trap in every wave. Dam har mauj mein hai, halqae sad kaame nihang. There are 100 crocodiles with their mouths open. Dekhe kya guzre hai. Katre pe guhar hone tak. Yeah, Katra is our child, which has started from the cloud. Let us see what all obstacles he has to handle till it reaches us and that therapeutic, that healing touch he gets. So this I found is very relevant and contextual. Ghalib has said in other contexts, but I find it we can use it here. So dam har mauj mein hai, halqae sad kaame nihang. Dekhe kya guzre hai, katre pe guhar hone tak. That is all from my side, sir. Over to you, Amit, sir, to
Thank you. Thank you, Dr. Shahbaz. I mean, this is a very good conclusion. I mean, poetic conclusion to it on this evening, beautiful evening. Yes, there is nothing more to add. I mean, Dr. Nishant has already, addressed all the queries related to management and assessment in ADHD. What we have, our clinical experience, we are using this psychoeducation part very effectively and very actively in all our patients. And in fact, we have developed a psychoeducation manual for teachers and parents as well. And we involve them actively. We always ask the parents to take feedbacks from teacher and to, include those feedbacks in management whenever possible, because nowadays schools are quite interested in, psychological part of kids as well. Every school have a provision of counselor. So we also talk to either with telephonic conversation or they can be, said to give their reports of child in school. So in that way, psychosocial intervention are important. MTA studies does show that medication and psychosocial interventions and psychological intervention, they are more effective, and the response to management treatment usually it increases by the introduction of parent behavior training and behavior therapy of children as well. I suppose this is a fruitful evening, and all of us are gain insight in the management of ADHD and its pragmatics, practical issues which are related to management of ADHD. So I hand over to Dr. Aleem, moderator for the session, and if we can call it the evening.
Thank you very much, Dr. Amit and Dr. Shahbaz Ali for the poems. Dr. Aleem is on move. It may be difficult on his part. I am taking over on his behalf and on my behalf both.
Okay, sir.
So my concluding, I will just want to reiterate the question raised by Aleem. So what, accepting drug holiday to be pragmatic, what is the right time to start it? Nishant, please.
Dr. Nishant.
So you want me to answer this question now?
Yeah.
Okay. So, sir, the right time to start, particularly stimulant, I'll stick to, stimulant if you ask me this question, is when a child is having obvious difficulties in his or her academics while in school, and they are, gradually entering into the they're finishing the primary school and entering into the primary class. So I would say the age of 9 to 11 years, this is the time when we offer methylphenidate if because of inattention or hyperactivity, the child is actually having difficulty having, doing studies in the school. So I usually don't use methylphenidate if there is no clear-cut history of academic difficulties because of symptoms of inattention or hyperactivity, sir. So this is in a nutshell about, there are other situations also, but this is in a nutshell which we use in our setup, sir.
One of my corollary from such observation discussion is that we are not considering attention deficit in children who do not go to school, and they are quite great in number. And when those who work with street children and people alike, they face it. This is a great issue. And second issue, which I want to raise it, so I don't need an answer. Need an answer is that living with a child with attention deficit, for parents, both of whom work and stay in a nuclear fashion, is quite difficult. And I would, Alim has raised his hand. Alim, please, come on.
Yes.
Allow Alim to speak. Shreya, please. Alim को unmute करो Shreya. अलीम को अनम्यूट करो. चिंतन थोड़ा अलीम को
Okay, yeah. He's online.
अलीम बोलो.
So thanks from my side. He did a wonderful job. Poetic angle, so it was ultimately a poetic.
Yeah.
One of the three of you. Thank you, Tufan Pati sir, and the Torrent team. And just one thing, there was one last thing, if Dr. Nishan can answer it. Many of us are under-treating ADHD because of the schedule.
अलीम chat box में लिख दो, हम पूछ लेंगे. I can't hear you. Chat box में लिख दो.
Sir, I've got his question. So if you allow me, I can just say a few words about it. So he's basically raising the very pertinent issue of underutilizing methylphenidate because of its precluded availability, because it's a scheduled X drug. So you have to maintain a lot of records, triplicate copies of prescription. So this is a problem. This is definitely a problem, and that too, if you're using the sustained release preparation or the OROS preparation, the problem is the cost. But I completely agree with what the concern what Aleem is raising, that pharmacological management point of view, methylphenidate is grossly underutilized and underused. And I said it's a wonder drug if it is used properly, pragmatically in an adolescent with ADHD. So this is my take on this. Thank you, Aleem, for raising this.
Thank you. So on behalf of Indian Psychiatric Council Statements, I sincerely thank Nishant for this erudite lecture. And he has done nothing more than expected because he's always excellent. Congratulations. And I am also impressed by the chairperson, Dr. Amit Arya, and Dr. Shahwaz Ali Khan, who has referred to Dr. Arsidas, a very good friend of mine, who is now in Bhubaneswar. Here, Marcel Arsidas. So, okay. Nice to hear yours. I welcome and I'm thankful to all the participants whom I am seeing over here, including Dr. Jagdish Thapa. And last but not the least, our moving moderator, Dr. Alim Siddiqui. I was also moving, I landed in my house.
Okay, great.
And now Amrit is also moving out. And from this, best wishes from this moving Thursday Musings. And thanks at the end to Tarun Pharma and the Thursday Musing team. Thank you, everybody. Good night. Have a good dinner. Have a good sleep. Sweet dreams.
Thank you, sir.
Thanks a lot, sir.
Thank you. Thank you, everybody.
Good night.
Nice.